So, is there any collaborative study with DNA, ICM, and HPV?
Yes.
Is there? What is the concordance?
There are several papers that were comparison. Like one of the best papers was actually done in combination with MD Anderson Hospital in the United States in Texas and BC Cancer in British Columbia, where they compared HPV, the conventional cytology with DNA. It was very clear that this is the best way. DNA is the best way. That's true, right? HPV test is
just telling you that she's infected.
Right. The problem with on one hand, the beauty of HPV is that great majority of cervical cancers, for sure, is caused by HPV virus. There is no question about that. The problem is that there is a lot of HPV infection. Much of this will never end up with us. So
Correct.
It's very high false positive.
Positive,
Okay?
exactly.
And then, so sensitivity is high, but specificity, meaning that is it real or it's not, is very low. It's not a joke to tell a patient
that
you may have cancer.
It's not.
Life of that person changes instantly that second.
Correct.
So you have to have high specificity. You have to be very sure that when you say that it's cancer, it's actually cancer. So this is the problem with HPV.
Because HPV positive doesn't mean anything. I mean, the female may go into malignancy, but the period may be 3 years, 4 years, or she may revert back to normal. So are they progressing to mRNA testing, RNA testing of HPV or something like that?
Yeah, of course. There's progression on this level. It's no question that at one point in the future, it may become very, very specific and also very less costly, right? It's not trivial cost right now, okay? So where the future is, I don't know. But today,
this is the best.
It will probably stay for a long time because this is fairly
established.
It's also like you as a pathologist, you do want to see cancer cells, no question, before you judge further treatment, further management of the disease.
Correct.
These are not trivial, right?
Yeah.
Taking biopsy is not trivial. Treating cancer is not trivial. Maybe it's not so serious in cervix because the loop excision and so forth are big, but outpatient procedures. But let's talk, let's say, prostate cancer. If somebody tells you you got prostate cancer, it's proven it's prostate cancer, but it's also known fact that of all absolutely proven early prostate cancers, that if none of these would be treated, only about 15% of people would die of prostate cancer. So now you're treating 100% of patients, of which only 15 should be treated, right? 50%. You see, this is the issue here, right? And how do we resolve that? Okay,
so we were discussing about false positive in HPV. How much false positive rate is there in DNA ICM?
So therefore it's in the high 90s, right? So that is the specificity. So therefore your positive predictive value is very high. So meaning if I tell you you got cancer, the probability that you do have cancer is virtually
high.
Very high. It's close to 100%. It's about 96, 97%.
Okay.
So there is some false positivity, but it's very low. And it is comparable to when people screen. Now HPV is way lower than that, right? And so HPV test positivity has to follow by more tests to see whether it's for real or not.